the data from both of you, and then I said in the beginning that redefining the disease severity and not just going by PASI as we did the last 20 years or 25 years. Do you think this should really flow into reassessing disease severity? So scalp, visual areas, genital, and so on?
I think that we have to consider that now patients who has affected genital psoriasis or scalp psoriasis or face psoriasis, there are severe patients. It's not important how compromised of the body area we have. At least because of that, I think we have to move very fast to systemic treatment and don't wait for topical therapy response. Maybe
the question to both of you, as Tiago was also joining. So you said you're faster going to systemic therapy. Should this be already included into the practice in general, that these patients, if they're not responding, phototherapy might not be an option, or usually is not an option for these patients, that they have faster access to, let's say, also biologics or other modern drugs, so that we, even though it's not classically in the reimbursement range in some countries, that they should actually have that?
Yes, I think it's that because, as I mentioned before, topical therapies has a high burden for treatment. There are very high cost. For example, in our Latin American countries, we don't have, for example, crisaborole, or we don't have roflumilast, and if the other drugs we have are very, very high prices, so we try to move very early. We especially use systemic traditional treatment because of cost, but now with the biosimilars, we can use more often systemic treatment, and it's a very good option for patients. Also biosimilars.
Thanks a lot, Tiago. Any comments?
No, I agree with you. I think we should start changing a little bit our mind. And these patients, the quality of life is really decreased due to the special areas that are involved, and we should start systemic therapies. And the biosimilars for sure is one of the options, because the price is quite decreased.
Yeah. So thanks the two of you for having accepted the invitation and giving these excellent talks and overviews. We took a little bit more time than anticipated. I apologize for that. Mostly probably due to my fault. So can we deliver the best value yet? I think we can in some regards, in others maybe not, depending on pricing and some also knowledge and evidence in luteate psoriasis. But I think I hope at least we gave you some insights in that regard, and it looks like the future is still very bright. Peter has joined us as well. Any comments from your side? You're on mute. He's struggling in the car. You should not drive and talk.
There is
a
question in the chat.
Oh, sorry, I didn't see that one. But then I'll hand that one over. So from Vera Mora, congratulations for the clear and updated talk. I would like to know how the side effects of biologics interfere in the prescription. I assume that's to Cristina. Side effects of the biologics, maybe have some decision on one or the other, that maybe scalp psoriasis might be some partially atopic dermatitis, seborrheic dermatitis-like, which can all be aggravated by 17 blockers, or I'm not sure if that was the question, but does the choice of a certain biologics impact depending on the site? Maybe also to Tiago, if it's more nail as well, you could rather go with a 17 blocker. If it's scalp, you rather go with a 23 blocker, or is that just random or based on other factors?
I'm mute.
You're muted.
Okay, I'm here. So, no, I think all these drugs are very effective in all different sites. Of course, we can find this one's a little bit more here or there. Probably IL-17s appear to be a little bit more effective in the nails. maybe in the scalp, probably all of them have the same kind of efficacy, a little bit more than TNF inhibitors. So I think the first thing is we should use these agents, systemic agents in these patients. This is the most important. Do not undertreat the patients.
Yeah, and I agree with Tiago. In other countries, access is the first limitation, no side effects, because all of the drugs are very safe. And in genital psoriasis, we have, more evidence with IL-17 and the story of ixekizumab, but now I show you, we will have more evidence with different drugs. So I think all of them are a very good option. Maybe with tuberculosis, we try to don't use anti-TNF inhibitors, but I don't think there are many other situations where we have to choose for safety reasons.
Yeah, I want to say as well. I mean, the biggest side effect is on the wallet. So not having access to these drugs is usually the biggest problem, on a global stage at least. Peter, any remarks from your side?
No, I enjoyed really the presentations very much. I think it is great to be informed more on the special sites and the therapeutic options. And yeah, I think it was very informative. Thank you so much.
Thank you.